Okay, everyone, we might make a start. Firstly, I'd just like to introduce myself, and my name is Sarah Annesley, and I work with Professor Paul Fisher at La Trobe University in Melbourne. And it's my great pleasure to, introduce the headlining act of our show, which is Professor Ron Davis. Professor Davis is a professor of biochemistry and genetics at Stanford University. He's also the director of the Stanford Genome Technology Centre. He has made many significant contributions to the area of genetics in science. He's including, but not limited to, RNA splicing, gene expression profiling, creation of genetic linkage maps, and as he mentioned yesterday, he was the first person to sequence a eukaryotic genome, that being of yeast. He's now bringing all this wealth of knowledge and experience and expertise to looking at the study of ME/CFS. He's the director of the Scientific Advisory Board at the Open Medicine Foundation, and we've heard some talks yesterday and the day before about some of the projects that are being undertaken under this umbrella foundation. Today he's going to talk to us about establishing new mechanistic and diagnostic paradigms for ME/CFS, and we welcome Professor Ron Davis.
First of all, I want to extend my sympathies for living in Australia that tells people to go exercise in order to get better, which is clearly you will not. And I usually advise them to say, why don't you go back and use leeches? It will probably do less harm. It has about as much credibility as exercise does in solving this disease. Anyway, it's something that's appalling that has happened, and it's very difficult to fight. So I would like to talk a little bit about some of the diagnostic ideas. We need a good diagnosis. I started out working on severe patients. I decided to do that because of very little work had been done on severe patients. It was largely because most of the work in the past has been done from clinics where patients report to the clinic. And they're not severe because severe patients can't go to a clinic. So we have to go to them. And so we've set up a facility where we can actually go to patients and collect samples. We're fortunately living in a metropolitan area that has a large number of patients. When I first started to do this, I found out that there were 4 bed-bound patients within 2 blocks of my house, and I never knew it. And it was only because of advertising that we want to work on this that they then contacted me. This first slide just shows you the level of severity, and I wanted to make sure people understood that. This comes from the severely ill patient study that we've done. Here's a bunch of other diseases, somewhat the same. Here's healthy controls, and here are the patients that are severely affected. It's like one of the worst diseases you could have. And it's also the least funded. And so these are what we call the SIPS patients, the severely ill patient study data. And I wanted to also show you a picture of my son, because it's, again, people don't get to see severe patients because they're bedbound. He has been in that particular bed for at least the last 6 years. He doesn't get out. We get to change his bottom sheet once every 4 months, and that's just done his own request because it's so difficult to do. And so this is not a pleasant living environment. He cannot talk. We cannot talk to him. He cannot look at letters They're too painful. He cannot look at numbers because it's too painful. So he cannot listen to anything. He cannot listen to music. He does have earbuds into his ears. I think you might be able to see that. And what he plays in those is white noise. So he listens to white noise all day so that he doesn't have to hear extraneous noises like birds chirping. If we have to go into his room, and that's all done on a schedule, and he puts on noise cancellation earphones on. He's super sensitive to smell. We have his door sealed, and then in a hallway we can then go into, and the door into that hallway is also sealed. If we cook something in our kitchen, within 15 seconds, he rings an alarm because he can smell it. So, I mean, this is not unusual. It's just that you don't get to see it. There's thousands and thousands of people like this, and they're so severe that there's just no way that anybody can communicate it. So one thing and if we give him Ativan, he can partially recover for about 4 hours. And he can recover sufficiently that he can look at us. He still can't see letters and numbers, and we can't talk to him, but we can do sign language with him, and he can sign back with us. And so we do get the chance to get a little communication. One of the interesting things we wanted to know about him, what does he do all day? And he says he lies there and relives the past. He also communicated with us that he will not kill himself, and we wanted to know why. And he said, when people see me, and he's allowed us to show these pictures, when people get to see me, they realize that, one, you can get a lot worse, and two, if he doesn't kill himself, other people won't either. Because they feel, if he doesn't kill himself, I can survive, because I'm not that bad. So he deliberately says, I will not, no matter how bad I get, I will not commit suicide. So I consider him a real hero. And what he's going through on a daily basis is incredible, in the sense of living like this year after year. Anyway, we need to figure out this disease, and we need to figure out effective treatments. And I'm convinced we need to cure it. Now, I think a lot of physicians would probably disagree with me on that, because they say we don't cure diseases, we treat them. And I argue this, you only treat diseases because you don't know the cause. And if you know the cause, like an infection, you can cure it. And now, I may be over-optimistic, but that's the goal. And in order to do that, this is not about an individual endeavor on my part that this is the research that I'm going to do, and I'm going to try to hold it. This is about a person like this. And we have to do it in the most effective way. And the most effective way is to collect the data and immediately share it. And we share this with Neil all the time. He shares back, saying, here's my ideas, here's what I discovered. And then that's a very, very effective way to get progress. All the data we've shared with him so far is unpublished. We're struggling hard to get it all put together and publishing it. Publishing is not easy. It very frequently takes longer to publish than it does to do the work, because reviewers find something they don't like and reject it, and you often go through multiple rejections before you get a publication. I wanted to share you with one of the things that came out, because I'm going to try to focus this a little bit on patients and what might be done. So it'll be a little bit choppy, but I think I'm just pulling things out that might be useful. One of the things that Wenzong, who's here, who's talked before, who's analyzing all this data, discovered that this compound, indole-propionate, was extremely low or missing in all of the severe patients. And of course, the first thing you do is there a mutation? Well, no, because the gene enzyme that makes this is not present in human. It's coming from the microbiome. And so this is an interesting concept, I think, that generally has not been shared very much. A lot of people think about the microbiome as a problem because it may have a bad organism that's producing a toxin, and that's what's causing the disease. Here's a situation where the organism that makes this is largely missing. So it's a situation where, in fact, you don't have the right bacteria. We don't know why all of these patients are missing this. It must be due to the environment of the gut that doesn't support the growth of this organism. It's a Clostridium. It grows in lack of oxygen. But this compound is obviously not toxic because other people have it. I haven't looked at a lot of data for only moderately severe patients. I have a little data on it. I'm not sure this product is missing in those patients, but it's something to consider as a potential treatment. This compound is considered a neuroprotectant, and so that would make some sense. Now, I have often argued that the microbiome doesn't seem to me to be very important from the point of view of making a toxin, because when my son became ill, he all of a sudden couldn't eat, nor could he drink. And in that situation, it was kind of an emergency. You can only live a few days in that state. So we had to do something that would actually feed him. He refused to go to the hospital to have a J-tube put in. He said he'd rather die, because he knew that going to a hospital, you would come back worse. So we managed to get a person to come into his bedroom and, using sterile procedures, put in what's called a PICC line. It was a line going into his arm, and that threads through to the heart. And then we had to have x-rays to make sure it was in the right position, and we found a person that had a portable x-ray machine that would come in and take x-rays to make sure it was in the right position. So when we did that, we were constantly sending samples of his blood to Metabolon, who had agreed, because of his severity, to run his metabolism anytime we sent a sample for free. So we would send frequent samples to him to see where he was, how he was changing. A few days after we put in the PICC line, we did take a blood sample and send it to Metabolon, and fairly soon I got an emergency call saying there's something dreadfully wrong with your son. He does not have any metabolites from the microbiome. And then that's when it made, obviously he doesn't have anything. We're not feeding him. The microbiome is basically gone. Now, it's not sterile, but there presumably aren't very much bacteria, and they're not producing any metabolites. There was no change in his behavior at all detectable. He was on the PICC line for a year and a half, and the problem with that is that you cannot go much longer than that or your liver will fail. And so we eventually convinced him that he had to go to the hospital and get a J-tube put into his stomach, into the top of his intestine. That's when we discovered, to quiet him down, because he was very nervous about going to the hospital, we gave him Ativan. And it really changed him within 5 minutes. And that allowed him to go to the hospital. We found a hospital that understood the disease and said they put him into a TB isolation ward where nobody would enter. And so that actually made it all possible. And then Bob Navio helped us get his gut restarted. It took a while, but once we got his gut restarted, no change. The microbiome came back, and we still didn't see any difference. Now that is assuming that there's something toxic, but it's totally consistent with something missing. And he's probably still missing that organism. So I think the microbiome is very reasonable to study, but you've got to consider both something being present that's a problem, as well as something being absent is the problem. So the other thing we'd like to try to do is get a biomarker. This largely comes from the fact that in talking to physicians would say, well, if you don't have any molecular diagnostic tests, then the disease does not exist, which I think is crazy, but that's how they view it, and we got to take it from that. So we have to get something that will say yes. So there is a large need, I think, at least to tell the physician that the person's not healthy. Something is wrong. It's not in their head. We'd also like to be able to distinguish it from other related diseases. That's important, but I think it's even less, it's a little bit less important than just saying that there is clearly something wrong. You can't send the patient home and saying there's nothing wrong with you. That's unacceptable. So the first pass of that is a commercial instrument called the Seahorse instrument. We got one of them when they first came out. It's now sold by Agilent, which is right in our area. This just shows you, and these are T cells which we get the best response from. And that response is, this is looking at the amount of capacity they have. And they're clearly, the patients are clearly less capable than healthy controls. And also what we found is if we treat the T cells with Ativan, they become normal. And I don't know why. Now, what you've got to keep in mind is that Ativan obviously works in the brain, as it operates on GABA receptors, but it turns out a very large number of cells have GABA receptors, including the T cells. So what you have to keep in mind when you talk about a drug having an effect, a positive effect on somebody, you don't necessarily know where that effect is. So just because it's a drug used to have a mental effect doesn't mean it's not doing a lot of other things. This is a good instrument. We're not terribly happy with it. It's a little tricky to do this repeatedly, and sometimes it doesn't work, and we don't know why. And it's a little expensive. The instrument's about $125,000, and each assay is a little expensive. But it is a good instrument for these things. There's a new instrument that we are getting in, which might provide us with more information. And we haven't tried it yet. We also developed another instrument, because I have a lot of electrical engineers working with me. I like working with them. Stanford has an excellent engineering department, which is in walking distance of the medical center. And I'm encouraging them to come in and do these things because doing biological medical things is a whole new area for them. So these aren't bioengineers, these are hardcore electrical engineers. And I like working with them because when you give them a problem, they say, okay, I'll go model that. And they go off and they model it to determine whether it will work or not. And they'll come back and say, it isn't going to work. And of course, initially I was naive and said, well, shouldn't you try it anyway? And they said, absolutely not, it doesn't work. So it saves a lot of time and money. Or they'll say, yes, it will work, and they'll get it to work. So this little device is nanofabricated. It has 2 electrodes of gold. They're very tiny. 50 nanometers is very small. It's large compared to computer chips today, but of course it's so small you can't see it. So these guys make instruments that you really can't see, and it's a little scary what they can actually make that you can't see. So all these kind of movies you see, sci-fi movies where they cut something out of their hand, come on, that's old-fashioned stuff. What you would be inserting next is something you couldn't actually see. It's too small. So what we can do with this is measure the electrical current. And you can measure different properties of the electrical current. And we determine what the right frequency cycling is and the right voltage for it. But in this, we have a trough with multiple electrodes, and there are 2,500 electrodes in this device. So the reason you do that is so you can get many, many independent sampling. And then we sample it, collect a measurement 200 times a second. So it creates an enormous amount of data, and that gets rid of a lot of the noise problems. So what we put into this then are, in this case, is blood. What happens with blood is a healthy person, when you put in this device, is very, very flat. We figured that we had to do, and the chronic fatigue syndrome is just the same. So we decided we had to stress the cell to make it respond differently, because there must be something wrong with them, and they can't deal with energy very well. So put in sodium chloride, they have to pump it out. So when we put in sodium chloride, this is actually the very first experiment, you see a small effect of adding the sodium, and then healthies are flat, ME/CFS patients increase, and this is the electrical impedance, which is a complex property.
Do the needles penetrate the cells?
No. Just a drop. It's a drop of blood put on the device, and it's just measuring the electrical impedance within the blood sample. We do get rid of the red cells, and the reason we get rid of the red cells is they also have a signal, but it's in the opposite direction. So when you put the two together, it kind of doesn't show very much. So we get a much better response if we get rid of the red cells. Now, this is actually quite cheap. You get a real-time measurement. It reflects the different response to sodium chloride. We tried other salts. Sodium chloride seems to work the best so far. It might be used as a diagnostic. Don't know yet. But we also think it might be possible to use it as a drug screen. In other words, if we put some drug in that actually helps, then the signal might go away. Don't really like using something where your signal goes away, because there might be a lot of reasons why a signal would go away. Often people say, well, we've done this on 20 patients. That's not nearly enough patients. You need to do hundreds and hundreds of patients. Well, that's the kind of studies where you have a small signal. When you have a clean signal, you don't need that many. And so here are the 20 patients. They all go up. They all go up above this line. Here are the healthy controls. They're always below this line. So the probability that you could get this from random chance is 10 to the minus 9. So it's better than the lottery. And so that should be sufficient. Now we've increased that number now to 30. We still see the same response. Every patient shows this response. No healthy control shows it. Now that doesn't mean that we aren't going to see something when we look at other patients, and we're trying to do those experiments now. I wouldn't be surprised we see it with other patients. And the reason I wouldn't be surprised is that we know that chronic fatigue syndrome is initiated by a stressor. Other diseases are stressors. How do we know that they don't also have chronic fatigue syndrome? So the first person we thought about doing is MS. So I talked to MS specialists. I said, and I just read through the list of the diagnostic criteria. You know, what happens if they exercise? Oh, they get worse. Are they fatigued? Oh yeah, they're always fatigued. They fulfill all of the requirements for chronic fatigue syndrome. I said, well, do they have chronic fatigue syndrome? And they said, no, they have MS. And they admitted to me that when you have a clean diagnosis like MS, all symptoms that the patient has is caused by the MS. It wouldn't even consider it that they have a second disease. Makes it complicated for us. Now we have tried this out on doing some drug screens, and this is a very preliminary result, but just to indicate that it might work. And it's only been one patient. It's been one patient that we tried several times. And there are two drugs, Copaxone, which is an immunomodulator, and a drug called SS31, which is a drug that repairs mitochondrial damage. So those were tried because of their involvement and what we think might be involved in this disease. And they get rid of the signal. If we pre-treat the cells, we get no signal. We don't know if it's going to work on a patient or not at all. And this is something that we're prepared now to work with some of the local physicians that treat chronic fatigue syndrome and have them try it. Both of these drugs are probably pretty safe. This one is available. This one is not yet approved, but will probably be approved soon. Now, we have done what's called a plasma swap experiment, and that is where, and I'm not going to focus on this heavily, but that is, for example, where we take plasma from a patient and mix it with healthy cells, and we get the signal. And if we do the reverse, the signal's gone. So most of what we're seeing is actually from the plasma, but the cells are required. If you leave out the cells, no signal. But so there's some communication between the plasma and the cell that gives us a signal. Now we decided to try another platform, and this was a collaboration with a bioengineer from San Jose State. And it involves a microfluidic device. He had this device, and then we decided to try to adapt it. And it's to look at blood flow. So he had a device that had a small capillary that you could image. And we decided to try putting red cells through it. And red cells have to deform in order to go through capillaries. And if they don't deform well, then you'll see a change in the flow of the cells. And you can just do this by imaging. So we measure the entry time, how fast it goes through, and how elongated the cells get. This looked very encouraging. I'm not going to go through the data for this, just to show you that it's a tiny device, takes a drop of blood, very easy to do. But since then, I keep trying to recruit people to get involved in this exciting program. And I've got a lot of reception at Stanford. So I got two engineers that thought this is really interesting. It's different than what they normally do. And so Eric is a chemical engineer. He was the past chair of the Department of Chemical Engineering. He's just recently stepped down and said, I want something new to do. He's a modeler. And this is what we wanted to do is model this to how to design it the best. So he's been spending time modeling the whole flow. Now, it's really complicated to do. But he has access to the U.S. Defense Department. And he's used the U.S. Defense Department computer systems to do the modeling. It's something beyond anything we have at Stanford. And he's just finished the modeling, and he has changed the way we should design it. So we're now doing a new design for this that will make it work better. The problem is we want to get rid of the variants. If we get rid of the variants, we have a better diagnostic. And Juan San Diego is a mechanical engineer. He's a world-famous instrument designer. He does things incredibly simple, very inexpensive, and very reliable. I'm amazed what he can come up with. He's come up with several designs for this that would be a little handheld device that would be very easy to do and run. So this is just an example of bringing in new people into the field, constantly bring new people into this, use their expertise to work on this disease. Now we have another device that we had for a totally different reason. It was mainly to isolate circulating tumor cells from blood. And it involves what's called magnetic levitation. You put in a fluid that is magnetic, and you put a permanent magnet on both sides of it. Very simple device. And that will generate a gradient in this magnetic fluid, and the cells will go to their density. And this is all done in a little capillary tube. So the cost of running this assay is 5 cents. And you will get the cells distributed. The red cells will separate from the white cells, which will separate from the tumor cells. The whole purpose of this, and it's all paid for by cancer research dollars, is to isolate the tumor cells, and you haven't done anything to the tumor cells. You can do this by putting in fluorescent labels on them, but now you've modified them. And sometimes that modification changes them. This is done without any modification to the cell, and you can pull out tumor cells because they have unique density. And doing this, and this just shows you an example of the separation of cells. You can do a good job even of separating immune cells. I don't want to get in a lot of data for this, but here she shows you you can get this distribution of cells. You can then put ports on the other side and actually collect them. And then this is about a year's worth of analysis. This is from my son over time. And the white cells are light, and almost consistently light. There's one example where it wasn't light. And in that example, it was right after he had a fever. And in many of these cases, after the fever, the cells get heavier, excuse me. Right after this particular fever attack, which is now normal, he, for a short time, got much, much better. So something happened during the bacteria. So he got a contamination in the PICC line, which happens. And he had 104 fever. And after that fever broke, and he got actually quite a bit better. And it didn't last long, but it did last short time. So that's another piece of data. Why would somebody get better after they have a bacterial infection? But this could be a very simple device. So we have, I just showed you a few of them. We have a number of devices that we can use for diagnostics. We also have been working with Robert Navio. The Open Medicine Foundation funded him to do a validation study, which he's completed, of metabolomics as a way to diagnose. And Robert Fair, who gave a talk yesterday, would argue that possibly the tryptophan-kynurenine ratio molecularly would be also a diagnostic. So we're going to try to run all of these on the same samples, and we have been doing that now for a while, and doing a comparison. Which is the best? It might require us doing two different assays. Now, with this, we call bake-off, we will start running other patients, and trying to determine which one is, or which combination gives us the best answer. There's one last thing I wanted to talk about. In fact, we had some nice discussion of this earlier, and it's everything that was said is consistent with what we find. And that is doing metal analysis. We started doing this because I recruited a person from environmental engineering, and she's an expert in environmental exposure. And so we wanted to look at environmental exposure. Here's an instrument that can measure metals that are present, and it does it by ionizing it into a plasma and then running it into a mass spectrometer and measuring the mass of the ions. And when you do that, you can measure all of these things in the periodic table. And then from that, we can look to see if there's something in excess or something absent. You can do this with hair. Now, I guess I'm told I'm a witch because we do hair analysis. And the reason we're doing hair analysis is the fact that it's so easy to ship. A person anywhere in the world can clip off some hair and mail it to us. And we've gotten lots and lots of hair samples. This instrument can also do blood and also urine. And we do all three of those. Another thing nice about hair, and we have a lady from Finland who just turned out to send us a length of hair about that long. And we said, well, what can we do with this? It's a shame that she cut off so much hair. But we told her we want the hair near the scalp because that's the recent exposure, right? So she sent us this whole. So we said, well, that's a timestamp, right? You know, and so we cut it up into little intervals and measured each interval. It turned out she had a lot of uranium exposure and a lot of mercury. And did she have an event that caused her to get exposed? No. For the several years, she has been constantly exposed. And so we've guessed that the mercury is probably coming because she eats a lot of fish. So this is a small analysis. We've done a lot more than this, but I just think this gets across the point. And sometimes aluminum is very high, and that could be a problem if it's very high because it can inhibit some enzymes. And that's why it's included in this list. It's the whole periodic table, but I'm pulling out what's interesting. Oh, we don't find cadmium in any of the patients we've looked at. So this is something that must be a problem in Australia with the ground. And we find only one person with lead. But mercury is not uncommon, and this is above the WHO safe level. It's not extremely high. But what's also interesting is every time you have a heavy metal, you have low levels of selenium. And I think that's because selenium binds to the heavy metals. And this is a problem if you have low selenium, because it's involved in a number of critical reactions, and it's involved in the conversion of T4 to T3. Many patients are low in T3, and it might be a selenium problem as opposed to something else. This is pretty common. The selenium deficiency in selenium is pretty common, and it's very easy to fix and very inexpensive. Uranium is found, usually it's very low, but there are a few people that are quite high. We don't know if this is this lady that had the long hair. This is a person from Finland. All of these others are from California. And we don't see it from any place else. I don't know why California has a lot of uranium. Someone said, well, Defense Department. I don't know the answer. Also, I really don't know the medical consequence of this level. We need to figure that out. But the selenium is actually easy to replace, and it's an easy thing to measure. A lot of the patients are low in copper, especially in California, but also all over the United States. Copper is often probably around a half to 2/3 of the American population are copper deficient, and that's because there's not much copper in the ground. And that's not true in other countries. So this has all got to be country specific. We don't see arsenic, and we don't see some of the other heavy metals. So with that, I'd like to stop and allow it to have some people to have some questions. Now, all I've shown you are some things that could maybe help. But we have not found the cause. We need to find the cause. Thank you.
Ron,
yeah.
Your microneedle device, and when you swap the plasma and the cells over, and you found that the plasma was containing something, have you tried using the mitochondrial inhibitors from the Seahorse machine to see if you can make normal cells have a bad signal?
Some of the problem with the Seahorse instrument is that it doesn't use plasma. It uses...
No. What I meant was, can you take the inhibitors that you use in the Seahorse machine, put those inhibitors into the sample you're testing with the microneedle to see if that inhibiting the mitochondria in the normal cells gives the same signal?
No. We've had a lot of difficulty with the Seahorse instrument trying to combine these things because of the required media that they put it in. They put in a lot of pyruvate, for example, and they've taken out the plasma. And so it's been very difficult to kind of compare results. We've tried this, but trying to compare results. There's another instrument that, I've forgotten its name. It's a new instrument. We've had a chance to use it, but it measures the metabolism from lots of different possible metabolites. And that so far looks like it might be a lot better instrument for this than the Seahorse instrument. I don't know.
Thanks, Ron. I just wanted to go back to a comment that you made right at the start of your presentation, and that is that if you know the cause, we might be able to cure it. So I'd perhaps like to take that to what I think is an even more exciting place, because potentially knowing the cause may not necessarily lead to a cure, because if it's a hit and run, it's like a deck of cards falling down, and it may be, quite some time down the track after the initial cause has been and gone. But what a cause may allow us to find out, which would be amazing, is to look at prevention.
To look at what?
Prevention.
Oh, yeah, absolutely.
Because if you know the cause and you can stop it.
That's another thing that we would like. That's another thing that we would like to try to. Kind of the next thing on our list, if we can get enough funding to do a study of that type. So there are a number of viruses like EBV, but that's not the only one, where the probability of coming down with ME/CFS is relatively high. The numbers range from, I think, 6% up to 10% of the patients convert to ME/CFS after they get over the viral infection. That's a very high and scary number, and that's occurring in people that are in the late teenage or early 20 years. So I would love to work with some physicians to think about that. That's too high a number to just ignore. And should we be putting these patients on antivirals? Now, I have limited experience with antivirals. We put our son on Valsite for a year and a half. He had no bad reactions from that at all. I eventually took him off because we shouldn't just keep giving somebody something unless there's a reason. And we could not find any virus in him. And so we decided to take him off. And it didn't change after we took him off. My impressions are that most people can tolerate some of these antivirals. And you wouldn't necessarily have them on long term. It would be to try to reduce the viral load and maybe the severity of the infection, and maybe reduce the number of people that convert. That's just a thought. This is something we can do the studies in the sense of collecting the data, need some physicians engaged in this that know infectious disease. I've tried that with a few physicians, say, oh, no, you would never use an antiviral, too dangerous. So do you understand ME/CFS and how dangerous that is? You got to balance it here. And I think it's these are the physicians that don't really understand ME/CFS and how bad it is. It's to them some yuppie flu kind of concept. And you're talking about a lifetime problem in this disease. And basically, they'll never have their life back unless we figure out some treatment or a cure. So I'm still a very strong advocate of trying to do prevention.
I just wondered if you had a theory yourself of why Ativan worked for your son.
I'm sorry, I can't quite hear you.
I just wondered if you had a theory of your own of why Ativan worked for your son. The drug Ativan. Have you got a theory yourself of why it worked?
Yeah,
to improve your son?
Yeah, I don't know why my son got so sick. I do know that he was always willing to push through things, and he was a fabulous photographer. And he just could not put his camera down. And he pushed himself way too far. Even after he got sick, he continued to go out and do photography. His photographs were shown in art museums throughout the country. And he just had a fabulous eye. There is something strange about him compared to other patients. As a severe patient, he is not light sensitive at all. Sound sensitive, touch sensitive, smell sensitive. All of these classic sensitivities are extremely high, but no light sensitivity. keeps making me think there's something having to do with his photographic skill. Something about his eye and brain that are extraordinary. And even the CFS can't put that down.
Sorry, in the interest of time, I have to move on, but there will be the breakout session later on that perhaps you might get a chance to answer those questions. So we'll just thank
Thank you.
Professor
Thank you.
Davis for his talk once again.